So when we feed the baby, we need to also be clear about whether we need to check for residuals. This is a very controversial topic. It's not very important whether we check for residuals or not, as we anyway aspirate to check the feeding tube position. The more important question is how we respond to the residuals if we do notice residuals. It's very important to avoid holding feeds unless there is a clear reason to do so, because each time we hold the feeds, we are losing valuable time, and there is that race we are having. Whether we need a second central line, the UVC can hold you till you reach full feeds, or you need to insert a PICC line. There is cost implications, there is handling of the baby, and then when the line goes in, there is a risk of infection as well. So many times the night shift, people hold feeds if they are worried. The night shift is not a reason to hold feeds. Your assessment should be the same whether it is a day or the night. And when you hold feeds at night, 8 to 12 hours is a really long time when it comes to the cumulative planning for the feeds in these babies. So how do we respond to residuals? We should use the smallest volume syringe for checking the residuals to avoid excessive suction and trauma, and never use the suction catheter, wall suction, to empty the stomach. So it's very dangerous practice. If the gastric residual volume is less than 30% of the cumulative feed volume, which is the total feed given since the last aspirate. So if you're on a 2-hourly feed of 2 ml, over the 6-hour period you would be giving 2 times 3 feeds, so it's 6 ml, and then 30% of that will be roughly 2 ml. So if you get a 2 ml residue out of a total of 6 ml feeds, it's a 30% residue. You assess the baby clinically, you replace the aspirate. So don't discard the aspirate, because the aspirate often has the baby's own secretions, the electrolytes that are secreted in the stomach secretions, the acid. So you'll be wasting all of that. So feed the rest of the feed volume as fresh milk and continue to monitor the baby closely. If the gastric residual volume is more than 30% but less than 50% of the cumulative feed volume, replace the aspirate but reduce the feed volume by 20% and continue to monitor. If the gastric residual is more than 50% and the baby is vomiting or shows signs of clinical instability, we may hold the feeds for a couple of hours, restart with a lower volume by 20 to 30%. However, if the concerns persist, you may need to keep the baby in peroral screening with abdominal X-ray and infection markers if needed. And we may consider reducing the non-invasive ventilation settings to improve feed tolerance if the baby will tolerate, because very often the NIPPV related flow is one of the reasons for the feed intolerance. So what are we able to do to improve feed tolerance? If a baby is on high flow, CPAP or NIPPV, we can leave the feeding tube open 15 minutes or so after the feeds, and preferably use a size 8 feeding tube so the decompression is more effective. Glycerin suppository may be used to stimulate stool output if the baby is not spontaneously passing stools for more than 2 days. More rapid evacuation of meconium during the first week may help feed tolerance. There have been many studies on use of glycerin suppository in the extremely low birth weight babies. Now, not conclusive evidence, but some of us believe, and if the baby doesn't pass stools over 2-3 days, we tend to give half a chip of glycerin. Acid suppressing medications like PPIs should not be used to treat feeding intolerance. They have absolutely no role, and as you know, there is an increased risk of sepsis and necrotizing enterocolitis from using omeprazole or other similar drugs. There is insufficient evidence to recommend the use of erythromycin for improving the feed tolerance, and most units use probiotics to reduce NEC risk. We start probiotics when we cross 50 ml per kilo per day in the babies under 28 weeks, and we continue it till they are 34 weeks.